Thanks, Bruce. I appreciate the opportunity to speak today, and I'm going to talk a little bit about hernia outcomes and clinical quality improvement and how we can make our practices better for our patients. These are my disclosures. I did receive research support from W.L. Gore and also from Karl Storz Endoscopy. So this is the challenge we have as hernia surgeons. First of all, most everyone in this room deals with the very heterogeneous disease process. Hernia disease is comprised of inguinal hernia, ventral hernia, peristomal hernia, non-abdominal hernias, including hiatal hernias and internal hernias. So really kind of pinning this down to identify what things we need to do to improve our outcomes is certainly a challenge. For purposes of this talk in this session this afternoon, I'm going to focus on ventral hernia solely. So why are outcomes important? Well, certainly we want to help patients improve their lives. Secondarily, we wish to deliver the best value in hernia care. And finally, we all take pride in a job well done. This is what we don't want to see. And this is what we don't want to see in our local newspaper. Surgeons are not accountable for their outcomes, and volume, not quality, drives health care. Unfortunately, this is the reality we live in right now. Arguably, we all strive to have good outcomes, but we don't really have a mandate to do so. And certainly, we all suffer from the pressures of our hospitals as far as increasing our outcomes, because that's what's directly driving our reimbursement, both for ourselves and for our hospitals. So why is this really important? First of all, overall, we have a finite set of resources and an expanding population for which to care for patients. Really, what we're going to be working under right now is this concept of value, and that is the relationship between outcomes and cost. The decision to operate has an enormous impact on value in healthcare. The decisions we make on a daily basis in our clinical interactions with patients set in motion a certain set of resources that is unlike anything we have in healthcare today. Certainly our goal is to maximize positive outcomes and minimize cost. What we don't want to do, of course, is to maximize negative outcomes and also increase cost, which is the worst situation. And certainly, why is this important? We need to justify what we do. In about 5-10 years, accountable care organizations are becoming more and more of an attractive option to reimburse us in our hospitals, and we have to basically work within that system, and this is going to be forced upon us if we don't take it upon ourselves to dictate what our outcomes are going to be. Quote from Hippocrates, "There are in effect two things, to know and to believe one knows. To know is science, and to believe one knows is ignorance." And unfortunately, in hernia care, we've unfortunately kind of been more of the latter situation, and that is to believe what we know is true when actually we don't really know. So how do we measure quality in hernia disease? Certainly, complications are important to all of us. The things we can measure pretty readily: surgical site infections, pulmonary embolism, myocardial infarctions, those type of things. Recurrence, we think we know how to measure that, although I'll present you some data to say that we really may not have a great handle on this, but certainly we all are taking pride in the operations that we do to minimize recurrence when we repair hernias. And certainly what's a little bit more difficult concept to get our handle of is that this quality of life and functional status after these operations, because we're all in the business in hernia repair to improve people's lives and make them better, of course. And again, it goes back to this relationship of outcome and cost and its impact on value. So all of these things here really impact outcomes, and we wish to maximize the positive outcomes. So looking at recurrence, this should really be just a simple yes or no. This is a patient, and I'll admit I've had a recurrence here, operated on her, she recurred about 6 months later. So this patient is pretty easy to deem as someone who recurred after a ventral hernia operation. But it's really not so simple. How do we define recurrence? Is it clinical recurrence, radiographic recurrence? Is the recurrence symptomatic or asymptomatic? And also, as everyone knows, it's very difficult to get patients back to follow up clinically or otherwise. Going back to Lewandike's original article in New England Journal of Medicine, still to this day, probably the best piece of evidence we have for what we do in ventral hernia repair. They assessed 3 years of follow-up and assessed recurrence after that time period. Of course, this was a randomized trial comparing mesh versus no mesh for ventral hernia repair. And the results were the following. They had a 23% recurrence rate with the mesh group and a 46% recurrence rate in the no mesh group. Well, let's take a look at this a little bit more carefully. How was recurrence defined in this study? And this is a quote from the study. "Any fascial defect that was palpable or detected by ultrasound examination and was located within 7 centimeters of the site of the hernia repair. Ultrasound examinations were performed only when physical examinations were not definitive. I think we glean a lot of information from this because even this group recognized limitations of clinical follow-up in measuring recurrence, and they used ultrasound as a backup. At Vanderbilt, we wanted to explore this a little bit further, and we basically created the Vanderbilt Incisional Hernia Detection Cohort, and the goal of this was really to define the best method of assessing incisional hernia recurrence. We prospectively enrolled 181 patients, compared clinical exam, the surgeon-interpreted CT scan, and surgeon-performed ultrasound. 68% were women, the mean age of 54 years, with a mean BMI you see there of 31. 33% of these patients had prior ventral hernias. So how good is clinical recurrence? I'll give you a little bit of the results here. This has actually been submitted to the American College of Surgeons meeting for this fall. But clinical recurrence is not good. There's a very high failure rate to detect incisional hernias. In fact, the positive predictive value of recurrence detected by clinical examination was 95%, and the negative predictive value here was 77%. So really what this means is if you use clinical recurrence alone in all the studies we've been looking at, you will underestimate pretty significantly the recurrence of a hernia. And it's worse in obese patients. This goes upwards to about 30% of a failure to detect hernias in the obese population. What about ultrasound? We standardized a technique called a dynamic abdominal sonography for hernia, or DASH. And you can see here, these are some representative sections using ultrasound. And the transverse cuts of this look pretty similar to CT scan, and we wanted to evaluate this modality as a means of detecting recurrence on a long-term basis. So how good is ultrasound or DASH recurrence? This was published recently in JACS. It's pretty good. We had a positive predictive value of 91% and a negative predictive value of 97%. In fact, we detected 4 hernias that were actually missed by the gold standard of CT scanning. So you really have a spectrum of options when we're evaluating recurrence, and this impacts not only our clinical practice on a long-term basis, but certainly when you talk about incorporating this into studies, how to accurately determine if a hernia has recurred or not. So on the spectrum of easy versus hard, physical exam by far and away is the easiest way to measure recurrence, and ultrasound arguably is the most difficult because you have to incorporate it into your clinical practice. Looking at the accuracy of these tests, DASH seems to be the most accurate, while physical exam is the least accurate. And as far as cost is concerned, physical exam, of course, is the cheapest, with CT being the most expensive. Well, what about patient-centered measures of recurrence? Going back again to Lewandike's study, they had some of this incorporated in their study already from 2000. They basically asked patients, were you aware of a recurrence at 3 years? And these results were actually pretty interesting. Of 139 patients who didn't think they had a hernia, 14 did have a hernia, so they had a 10% failure rate there. But of the 42 patients who had a hernia, all had hernias. So really, patients know, and arguably if you just had a 10% miss rate in that first group there, that's overall pretty good. So again, going back on how we measure success in hernia repair, going back to the relationship of outcome and cost. Quality of life is becoming more and more a metric by which not only we as surgeons are evaluating our outcomes, but how hospitals evaluate us. So traditionally in surgery, we've used a lot of generic quality of life measures, including SF36 and SF12, specifically in hernia repair to assess our outcomes. Let's talk about these for a second. The advantages, number one, they have face validity. We've all heard of them. They've been used in multiple studies, and they're very familiar to us overall. But they have some pretty significant disadvantages. First of all, you cannot compare results between one disease process versus another. And also, these were originally designed for chronic health states, notably dialysis. And so kind of extrapolating the results we get from SF36 or SF12 to what we do in our own practices is pretty difficult. Hernia-specific quality of life measures were then developed, which kind of have a little bit more eye towards what we do on a daily basis. And this most notably is exemplified by Carolina's Comfort Scale, which has been used in multiple studies. And then the idea of functional status is becoming more and more of an important concept in ventral hernia repair, and specifically abdominal reconstruction. Rank Rosen's group in Cleveland developed the Hercules assessment tool to really target functional status after repair of ventral hernias. This is designed specifically for this goal in mind. It's basically a 0 to 100-point scale. It's reliable and valid for ventral hernias, and certainly should be something we should be using on a more frequent basis here. What about cost? Basically, cost can be very variable in the repair of ventral hernias. It's largely dictated by complications, prosthetic choice, operative time, and when you look at recurrence and cost together, we have some very interesting numbers that come about. So we did a study a couple years ago that showed for each 1% reduction in recurrence, very conservatively, there's a $32 million savings in costs nationally. And this is important because these numbers are the numbers that get attention on a national level, and I think this gives us some reason to do what we need to do, and that's reduce recurrence and improve functional status in our patients overall. Einstein said insanity is doing the same thing over and over again and expecting different results. Unfortunately, ventral hernia repair has suffered from this problem for the past several years, and we certainly need to change that. Well, how can we improve quality in the care of hernia disease? Caring for the surgical patient is a very complex system process, and Bruce will get a little bit more into that later on this afternoon. Quality improvement is definitely a local effort. We cannot exist in a vacuum, yet the decisions we make on a day-to-day basis are the ones we want to impact to improve quality. So really, individual surgeons need to use their own data to improve value. Well, how do we get the data? How does the data come back to us? Practically, what can we do as surgeons if this is such an important thing? I'll mention this. We have, at the American Hernia Society, and now in collaboration with SAGES, are developing the American Hernia Society Quality Collaborative. This is a comprehensive national quality improvement project targeting change locally. And it's very important because although you participate on a national level in this collaborative, the expectation is you go back home and make changes to try to overall improve the quality of care of your hernia patients. One of the keys also is this is not just inputting data into a large database. This is obtaining real-time outcome data. It's powered by the group out of Michigan by Arbormetrics. And we anticipate having 4 collaborative meetings per year to improve outcomes for patients. And there's the website there. It's www.ahsqc.org. This is a quick video of what it looks like when you log into the interface, and it kind of shows you a little bit of some of the interface interactions and all the outcomes here. So here, I'm logging in. This is the website itself, and we'll initially kind of go to the patient selector group here, and I'm selecting a morbidly obese patient who's had multiple recurrences named Mike Rosen. This is not real data, so I had to make it up. But this is what the interface looks like here. So these are the preoperative and operative variables that can be collected, and it's a pretty user-friendly mechanism. Again, this is designed by surgeons for surgeons. It incorporates the European hernia classification system. And one thing we had trouble was defining, well, how do you even begin to get a hold of meshes in this whole system? So here we can define where the mesh is placed, and there's a drop-down menu to select all the different types of meshes that are out there on the market. And this is provided by our WashU colleagues. And one of the most important pieces of this is, of course, the data reporting mechanisms. And here's also the follow-up mechanism of patient-entered follow-up and also surgeon-entered follow-up. And moving on here to the outcomes, here you can immediately see in real time as you enter data, that's you in the green compared to everyone else in the blue in the collaborative. So as data gets entered, you will immediately be able to compare your results to the collaboratives themselves. And this is the information that needs to get back to us, which unfortunately was a failing of a lot of national database efforts. So here we have real-time risk-adjusted outcomes coming back to us. We can use this to improve the value for our care of our hernia patients. Thank you.